Welcome to the Death Happens podcast, an insider's guide to dying. We're your insiders. I'm hospice nurse Penny.
And I'm Hallie, hospice social worker. Today, we're going to have a fantastic palliative care doc, Matt Tyler. But before we get to him, I hear there's some hot topic about some lady in Oregon that Penny's going to share with us.
Yeah, so I just read this the other day. There is a mom in Oregon who was just sentenced to 6 months in jail for giving her daughter CBD when she was going through her cancer treatment. So her daughter had cancer, liver cancer, I believe, and she started giving her CBD. Now, that's kind of only part of the story because the daughter was 13 at the time and she had been undergoing chemotherapy. She had 3 chemo treatments and she was scheduled for surgery. And the mom did not have confidence in the surgeon and did not want her daughter to have surgery. So she took her daughter and fled the state and then gave her CBD to try to treat the cancer instead. Now, I don't know if the daughter returned to the state and had the surgery later. She's 17 years old now, and she is fully supporting her mom. She has, nothing bad to say about her mom. So I just thought that was a really interesting story. I'm not a real proponent for things like lemon water, soursop, CBD, but that's because my limited experience with that is from hospice patients who wanted to try those things. And of course, we always say, you do what you want to do. We're not going to try to stop you, but it didn't work and they died.
Yeah.
But I've also had patients who did chemo treatments who died. So I'm not that sure that works either. But I just thought it was a bit of a harsh sentence to send this mom to jail for trying to do something alternative to try and save her daughter's life.
Well, I'm curious how much of that was the fleeing with your child. I'm assuming that was without the father?
Yeah, she had full custody. That none of that had anything to do with her fleeing the state. According to the article I read, it was really strictly because she medicated her with the CBD and did not seek the treatment that was recommended.
Oh, that is so tough because think about all the times that people have had religious objections about blood transfusions, etc. And when it comes to minors, where's that decision point? Oh,
yeah.
That's rough.
And her daughter's alive. She lived. So I don't know what else happened with that, but I just felt like, that just seems a little bit harsh to me.
Oh, yeah.
All right. So shall we do this?
Yeah.
Let's do it.
Matt, welcome. We're so excited to have you. Please tell us a little bit about yourself.
So yeah, hi, I'm Matt. I'm a palliative care doctor, although I wear a few different hats these days. I came to palliative care by way of internal medicine, and pretty early on in my residency, I found palliative care by happenstance and pretty much immediately fell in love with it. I became the resident that was like gunning for palliative care from intern year. And went straight from residency to palliative medicine fellowship. And I've been working as a full-time palliative medicine doc ever since then. So I mostly do inpatient palliative care work, meaning seeing folks in the hospital who need help with symptom management or help making a difficult decision related to their care, and anything in between related to their quality of life. But I do some work with hospice as well. I do some work on the outpatient side for folks at our cancer treatment center. So kind of get a little bit of taste of everything these days.
Well, I think we know in this room about the difference between palliative and hospice care, but I would love for you to let other people know.
I would love to tell you.
Side note, that is one of the most frequent questions that I get when I am doing a live on TikTok. People ask me constantly. I have finally created a playlist, and my moderators will get in the comment section and say, go look at her playlist, because they ask me constantly, what is the difference between palliative care and hospice? So I know it's a very hot question.
For sure.
Yeah, it is. Yes, very much so. And that comes from the shared origins. Like this all started with hospice care with Dame Cicely Saunders back in the day, as you know. And over the years, we wanted to reach more people because we all know that your quality of life is impacted long before you're eligible for hospice care when a serious illness enters your life. And so palliative care sprung from this desire to help improve quality of life for more people earlier while they were getting their other medical treatments for something like cancer. And that's really the main distinguishing factor is while both palliative care and hospice are there to focus on what's important to you and build plans around it, palliative care is meant to give you that quality of life support alongside your other treatments, whereas hospice care kicks in once you're at that point where treatments just aren't working, which is often when your life expectancy is 6 months or less, and where hospice kind of takes over as your kind of full care coordinating team.
Fantastic. That's a good explanation. And yeah, Penny, you're totally right. We hear that all the time. And when is the right time to come on to hospice? Well, and unfortunately, I wish more places had better or even any palliative care programs. Hope someday.
There's starting
Yeah.
to be more, though, I have to say. In fact, and I'm really curious, I think there's some reimbursement now that's happening for palliative programs, isn't there? I know there's a lot more pressure for hospice agencies to have palliative care.
Yeah, so yeah, we can take that a few different directions. These conversations are tricky because the regional variation is so vast still, and you're going to see
Mhm.
palliative care cluster in big academic centers where they have everything all the time. Whereas in the rural areas, same as hospice care being hard to come by and hard to get choice out in the rural areas.
Mhm.
Same with palliative care. You may not have any palliative care teams out there. We can circle back on how to find a team though in a second here. Um, but the sorry, I lost my train of thought. What were we talking about?
Rural. More places getting into having
Yes,
palliative care, and if there's
yes,
reimbursement.
yeah. So a lot of hospices have added on palliative care teams to try to expand their reach and kind of carry their mission to more people before they're hospice eligible, and it becomes this nice natural transition. Once treatment's no longer working, then you kind of move over to the hospice arm of that same team. Um, there are a few independent palliative groups, I'd say, in the community. They're fairly rare. Usually the independent palliative groups, meaning not affiliated with a hospice, tend to be at academic medical centers and seeing folks kind of like you would with any other specialist there. And Penny, to your point about reimbursement, Medicare a few years back created a reimbursement code for advanced care planning, which is certainly within the wheelhouse of palliative care specialists, although that code is not exclusive to palliative care per se. So when it comes to getting coverage or reimbursement for palliative care, we bill insurance just like everyone else. And on the patient side, you kind of have the same co-payment, co-insurance, and all those other fun word soup things, just like any other specialty that you're seeing.
And you mentioned there was a way that people can find a palliative care team?
Yes, one of my favorite websites is called getpalliativecare.org. And on that website, there's a great FAQ and kind of myth busting section about what palliative care is and what it is not. And on that same website, there's also a palliative care provider directory where you can type
Great.
in your zip code and then you can click a button if you're looking for hospital based, community based, clinic based, and they'll tell you what's in your area. And this database is kind of linked to CAPC, the Center to Advance Palliative Care, one of our big national organizations. And it's only as good as people are participating in it. So if anyone watching is of a palliative care organization themselves, make sure that your team is on there so people can find you.
So that's getpalliativecare.org. I wrote that down. I'm going to put that in the show notes. I love
Awesome.
CAPC. CAPC has fantastic training for hospice clinicians as well. I've learned a lot through the CAPC trainings. I don't know if they have anything that's more consumer focused. Do you know if they have anything that's not healthcare professional focused, but more consumer focused on CAPC?
mostly clinician focused, either for folks learning kind of boots on the ground skills like communication skills, pain management skills, and opioid conversions, that sort of thing. And there's a lot of great resources for healthcare providers looking to start a palliative care clinic, inpatient team, all sorts of stuff for kind of getting that up and running. But yeah, mostly healthcare provider stuff.
Well, before we move on to social media and all the craziness that that entails, you mentioned how much you love palliative care, and that was just your focus right off the get-go. I'm wondering if you have a favorite palliative care or death experience that you'd be willing to share, or more than one. That's okay.
Yeah, so it's honestly more of a patchwork of experiences, and what I mean by that is that I think we kind of go into medicine to connect with people, and I think a lot of people go on to fix things, but I think I certainly kind of went into to connect with people, and very even early on into medical training and residency, it's very machine like, right? You kind of got to get through the day and see the patient so you can put in the order, so you can write the note and get out of there. And there wasn't a lot of time for just sitting down and connecting with people. And when we did, it was very much like telling them like what they needed to do, right? Like, you need to do this and take this and be back in X number of weeks. And when I worked with the palliative care team, the whole thing was just flipped around. We flipped the script entirely, and rather than saying, you need to do this, the whole thing was, what can we do for you? Like, how can we, as your healthcare providers, help you live better on the terms that you define, not the ones that we define? And it was just encounter after encounter like that, where I just get to sit down and talk to someone and kind of understand their life and what was important to them, and how often it was unrelated to their statin or their blood pressure medicine, or their next follow-up visits. They just wanted to go fishing, or just be with their grandkids, or go on another trip with the family. And the stuff that we were trying to do to help them actually very often getting in the way of those things that they really wanted, with sort of this nebulous promise of more time. But then it always comes down to like, well, when are you going to get to spend that time if you're here doing all this shit that we're telling you to do in clinic every week? Like, you have other things that you want to do. And, for a lot of people, that works for a long time, right? The traditional Medicare or medical system works when you're relatively healthy. But once you have something chronic or serious without a fix, very quickly trade-offs into the picture. And I think we have to be a little bit more choiceful about what we're asking people to do and how we're asking them to do it, and really making sure that it's aligned with their own expectations and hopes and kind of what we call their goals of care.
I love that. I wish palliative care could just be integrated into all healthcare.
Yes.
Amen.
I mean, we could go on for, I'm sure, all three of us, days and days and days about our healthcare system and how broken it is. But I just love that. When you said that, what did you say? You learning about what was important to them, or being able to connect with the patients instead of just trying to treat their illness.
Yeah.
I love that so much. I refer to that sometimes in my videos when I'm talking about why patients might be a full code if they're coming to hospice, because their providers have never been trained to have those conversations with them. They are not comfortable talking about death. Death is seen as a failure. And, they're, in their defense, they are taught in medical school how to cure people, how to make people better. So I love that, that you identified that so early on, that you wanted to be able to connect in a different way with your patients and find out what was really important to them. Because, really, that's what it's all about, quality of life.
Yeah. And to that point, too, it really made it easier to deal with death, actually, by seeing more people and talking to more people and understanding trade-offs that they were willing to make. It honestly made the deaths easier to deal with. It made the full codes easier to deal with, because I knew that once you had kind of an eyes wide open conversation with this person and understood, what was important to them and what sorts of things were they willing to gamble or trade off, or whatever term you want, you have enough of those conversations over a long enough amount of time, you're going to get some full codes. There are going to be some people who really want to do everything humanly possible to squeeze like every last heartbeat out of their body. And you just learn to be okay with that, because you recognize
Mhm.
just on a population level, there's the whole spectrum of wants and desires and hopes, and beating that heart as long as possible is that for some people. And it's honestly been a massive prophylaxis against burnout for me, is just being better at understanding what people prioritize.
Oh, that's such a great point. It makes me makes me really wish that I know I've heard that more doctors training are starting to incorporate those end of life rotations with hospice, rotations with palliative care, more education on it, but it's still minute compared to the training they get on curative care, and how
Yeah.
much more they can do even on the curative side. I get we live in capitalist society. We're never going to stop that. It's a business. But how much more could they actually get done even on the curative side if they did have time to spend talking and connecting with their patients?
Yeah. And it's hard when it is relatively low reimbursement, and when you can get paid more for spending less time by just saying, okay, like, do you want the feeding tube? Sure, man. Like we'll put you on the schedule for tomorrow. It takes less time, and you get reimbursed higher. And yeah, I mean, the deck is stacked against having these conversations.
For
Yeah.
sure.
So here's a question. I say palliative. I heard Hallie say palliative. And I think I've heard you say a kind of a combination of the both. What is the actual correct pronunciation? I used to say palliative, and then I don't know, somewhere along the line I started hearing palliative, and I thought palliative is the right way to say it, and now I'm unsure.
I think that's one of those regional variation things that we were just talking about. But technically speaking, palliative. So four syllables there. But I think you were both equally
Well,
understandable
you are going to
the way you pronounce it.
or palliate. Maybe it's palliative. Palliate symptoms. So I guess palliative is probably correct.
Granted, I'm from St. Louis, so I have whatever accent that is that I bring to the equation here. But I've always said palliative, which just last week I introduced myself to a patient. He said, "Oh, you're a foot doctor?" And I said, "No, nope, not
Very
not that.
different pronunciation.
Different specialty with a P." Yeah.
Oh gosh. All right. Well, I think we've all been excited to ask you. Your social media handle is How to Train Your Doctor.
Yeah.
I've seen a few of your inputs on that, some videos.
I'm obsessed. I'm obsessed with your videos. I love every time I see one of your videos, I'm like, God, I wish I would have said it that way. I mean, yeah. So how to train your doctor? How did you come up with that? What's the story behind that?
Yeah.
So, I mean, that particular handle, part of that's because I love the movie How to Train Your Dragon, so that's sort of like in my head. Because I bring that like sort of like nerd pop culture to like everything, whether subtly or not so subtly. But I mean, to the point that you were just making, Penny, a lot of this comes from this notion that doctors don't get this sort of training. Like, we don't get standardized training on how to have difficult conversations and talk to people about death and dying, and in a way that's actually patient-centered and not like heavily laden with our own personal agenda to try to talk people out of something that we don't want to do. But from an actual patient-centered point of view, we don't learn how to do it. And every now and then I'll get a doc saying, "Oh, we learn how to do it." And I was like, "Yeah, you get taught spikes." Like, yes, we all get the stupid spikes model, and it's fine. It's fine, but not sufficient to meet everyone where they're at for all things. So part of that was that. And then the other part of that was when I'm seeing a patient at the bedside, as is tradition, we always ask someone, "Do you have any other questions? What questions do you have?" And very, very frequently, and I'm sure you've heard this too, the person will look at me and say, "I don't even know what I should be asking right now."
Yeah.
Because
Yeah.
how the hell can you? Like, with the medicine being so complicated, serious illness being so complicated, the different decisions you have, even the ones that you know about, are incredibly complex with very opaque trade-offs. And then there's all like the secret menu stuff, like that you don't know that you can ask for. There's like the In-N-Out burger with like, yeah, there's the hamburger, there's a cheeseburger, and then there's pleasure feeds. And it's all this stuff that people don't know about. And when I'm working with them, we can walk through that, and I'll say, "Well, we didn't really talk about this, but maybe we want to touch on this, but maybe we've touched on all of it." And I can just provide reassurance to say, like, no, like this is just hard. Like you will second guess literally everything that you do, even when you've done it all right. But I can only do that for people I'm literally working with. And there's so many people out there who don't have a palliative care physician or even a team in general. They don't have that kind of reassurance because, again, regional variation.
Mhm.
And I thought, well, wouldn't it be great if I had like something for people to find or stumble across and find a nugget here and there to provide that reassurance or guidance, just give them a little bit more than they have currently. And that's sort of my remedy for the massive amount of gatekeeping, because not only is there regional variation, but even where there is palliative care, you have to get the referral. You have to have another doctor who thinks about palliative care and that it's the right time for palliative care, which is a whole other thing. I can rant for that for the next hour if you'd like.
So you can't self-refer to palliative care because you can self-refer to hospice.
So it depends on your individual situation. So if you're in the hospital, for example, you could theoretically make enough noise that your doctor just, gets the palliative care team to come in and shuts you up. But again, most people don't know we exist unless you're very savvy. So you don't know to ask for something that you don't know exists. And then depending on your insurance coverage, if you're in an HMO or something, you do literally need a referral from your primary care doctor. Whereas if you have a PPO or something, you could technically self-refer. So it depends on the situation, but we're one of those resources where people don't always know that we exist, or if they do, they don't have the right understanding of what we do, mixing us up with hospice and things like that. And I mentioned I'm from St. Louis, Missouri, which we kind of informally go by the show me state. So rather than just getting on social media and telling people you should get palliative care, have you thought about palliative care? I wanted to literally show them this is the stuff I talk about, this is how I think about things, and this is sort of a flavor of what you'd have if you self-advocated for that palliative care referral. Because my end goal was just, as you said, to get people to self-refer, either literally or just by making enough noise that their doc referred them. And in a perfect world, making enough noise that we do get some decent reimbursement, we do get decent growth in the amount of resources we have across the country. Because we've been doing this long enough. We know how change happens on the healthcare level. We make it financially inconvenient to do it any other way, right? You have to tie it to people making healthcare systems choices that are going to cost people money if they don't do the right thing. And that's sort of my scheme, right? Is just to, cause enough noise on social media to try to slightly tip the lever towards meaningful reform.
It's funny you said that about How to Train Your Dragon, because when Hallie and I were doing we were recording the intro, and she said, well, today we have Matt Tyler, How to Train Your Dragon.
Yep,
it's such a good flick.
We could have just gone with that had we known. Could have just stuck with that. So you mentioned spikes. What is spikes?
Thank you for asking. It is our tried and true acronym for breaking bad news. So this is kind of the boilerplate acronym that we teach med students and residents. So if you got to break bad news to a patient, we use the SPIKES model, which stands for S, which is set the scene, meaning have a quiet room, turn your pager off, make sure family is around, whoever's important to the conversation, get them there. And then P is gain the patient's perception. What have you heard so far? What do you know? What do you not know? And kind of understand where they're coming from before you get into the information. And then the I is the invitation, where you ask, can I share this news with you? Which is, sort of like the warning shot, because no one asks to share good news, right? So sort of the posturing, but giving them a minute to tune in and understand what we're about to do. And then the K stands for knowledge, where you actually share the bad news itself. We found cancer, or the cancer is growing, or this looks like dementia, whatever that news is for this person. And the E is where you respond to the emotions, where you kind of throw in this must be hard. And again, it feels very robotic when you just have a spot on the line to respond to emotion. But it's there to remind us, docs in training, don't forget to be human. And then the S is where you summarize the situation and set your follow-up plans and all that. And so that's sort of the roadmap we give to docs in training who hate sharing bad news. Honestly, it sucks.
Yeah.
And you get in your own body, in your own head very quickly, because you're just like, you're nervous. You feel like you've messed up or failed somehow, even if it's something completely out of your control. Like, no one wants to share the bad news, right? We go into medicine to fix and heal. And then you've got this sort of like clash of identity here where you have to like share this terrible thing. And so it is very easy to get flustered and lose your train of thought. So we have this roadmap to kind of help people make sure they're going through the steps to try to deliver this bad news in the most humane way possible.
Well, shoot, I didn't realize I'd been to med school. I've been doing that for years.
I know, same.
Yeah.
Yeah, it's amazing when you have a person that comes onto hospice who wasn't aware that they had a life expectancy of 6 months or less. The doctor never told them that. They just said,
Yeah.
hospice can get them a lot of extra help.
Wouldn't you like some more help at home? Wouldn't that be great to have a visiting nurse? Yeah.
Oh, the only way you can get out of the hospital is with a hospice referral.
Oh, yeah. As a matter of fact, we have had an issue with that with one of the agencies that I work for, because we're starting to flag out on patients who are discharged after day 61, which is when the Medicare payment goes down for hospice patients. So we're flagging out, and on one of the reports that we get, I won't go into the detail because the listeners probably don't care about that, but so we have to look at why is this happening? And our medical director did an audit of the patients that were discharged between this time frame that we flagged out on, and said, they were discharged appropriately. They lived longer than 6 months. And I said, well, were they admitted appropriately? And she said, probably not. But the hospital is pressuring us to take these patients because the adult family home is refusing to take them back unless they're on hospice. So now we're referring them to we started a palliative care program. And now we're saying we're going to put them on palliative care and support. And then if we still see that they need to be on hospice, then we can bring hospice in. But as you guys probably know, many times when patients look like they're ready for hospice when they're in the hospital because they've been, they're sick, but they've also been tanked up with antibiotics to treat their UTI. And then they get home and all of a sudden those antibiotics kick in and they don't look like they're dying anytime soon anymore. So it's a real problem for us. But that's what we put in place to try to avoid having these patients that are coming onto hospice and they're not really at end of life yet.
And that's what's so sad is they obviously all benefit from hospice, right? You get all this great support in the home, and I think it's often hard to tell, like, did you get better despite hospice or because of hospice?
Right.
And I think this is especially true with folks with cognitive issues and dementia, where the main treatment for that is TLC, and you bring in all this extra help and you help the caregiver, and everyone is just doing better because you have more help. And then, you got better because of the help, so we're going to get rid of the help. And it's just, it's very frustrating.
Was that you that just did a video about graduating hospice and how it can be traumatic because they're going to live longer, but we are pulling back that extra support. Exactly like you're saying, people may live longer with hospice.
Yeah, it's not like they don't need that support anymore. And this is really where I feel like my videos are starting to shift is to all the system bullshit that just frustrates us every day.
Which I find very helpful, by the way. You did a Medicare one.
I'm glad.
You did that Medicare one recently, and so my husband just turned 65. I thought Medicare was free. I found out that it's not. Now, Medicare for hospital is, but the Medicare medical is not only not free, it's fucking expensive. It's more expensive than the health care that I can get for him through my employer. So I was shocked by that.
I was so glad you talked about getting rid of the Advantage plan, because we were all just on pins and needles waiting for that to not go through, or hoping that it wasn't going to go through.
Yeah. Oof. I've gotten some heat for whenever I shit on Medicare Advantage, I'll tell you. I've ruffled the feathers of an insurance broker or two, I can tell you. But honestly, I think one of the most common misconceptions about our work in palliative medicine and hospice care is that everyone presumes that the death and dying is the hard part and the depressing part. But it is 100% witnessing the broken system and how it abuses people for
So
all
much
the
that.
yeah. It's like, everyone's gonna die, but we don't all need to get prior auth denials, right? That's not like naturally inevitable that we're all gonna get insurance coverage denial or be like sent to an understaffed nursing home. Like, these are man-made phenomenon. Like the death, like, has been there the whole time. We really can't get rid of that part. And I think we all go into this role because we understand that, and we're just trying to make it a little bit better than it would be without us. And it's more hopeful and uplifting than anything, right? Because you're like, I get to take a shitty thing and make it a little bit less shitty. Like, that feels good. But all these systems issues that we can't, like, I can't just like stroll into Congress and be like, do it differently.
Unless you want to ban TikTok.
Oh, right.
Then you can get Congress to agree on something.
Yeah, we'll see. I'm not holding my breath for that one. But yeah, I mean, just seeing the broken system and all the million different ways that people just get caught up in it and just taken advantage of, abused, and let down. That's the hard part. And why every now and then I gotta go on and just blast insurance programs.
Yeah.
Otherwise, I don't know. You explode.
I mean, there's so much. I have so many more people now coming to hospice with, it's not even the death and dying part, like you're saying, it's the bureaucratic pain before they got to us. And then you're going to add on this advantage plan where it's taking away more benefits. It just was infuriating. So I'm just really relieved it's not going to happen.
I mean, even the possibility that you'd have to get a prior authorization for hospice care was fucking terrifying.
We already have to do that for freaking commercial insurances when they're too young for Medicare.
Yeah. So I'm glad that's gone. I'm hopeful that Medicare is going to take another closer look at the concurrent care model, which for listeners unfamiliar with this is sort of dispensing of the notion that you have to pick disease-focused treatment or hospice care. And so long as your life expectancy is likely less than 6 months with or without treatment, you can get all the great wraparound supports of hospice. This is already done in pediatric care. This is done in veteran care. So it's, it's already been proven multiple times over to be an effective model. And Medicare has experimented with it, but it's been a little bit quiet lately. But I'm hopeful we'll come back to it because, why force the choice? Let's just people get great care.
Yeah, they are piloting with some hospice agencies. Actually, mine is one of them, allowing people to continue dialysis and come on to hospice.
Wow.
Used to be you have, I mean, it still is with most hospices, you have to be off of dialysis. Well, they're recognizing that doesn't give people a whole lot of time on hospice because when you stop your dialysis, you die fairly quickly. And so
you don't get 6 months.
No, you don't. You don't get 6 months. You definitely don't. And then there's also the other end of that spectrum. And those are the patients who have dementia and they don't even get to benefit from hospice because by the time they're in that last 6 months of their life, they're gorked. I mean, they're zombies. I shouldn't say zombies. There was a big, huge medical creator that called them zombies and got blasted for that. Rightly so. But what I mean is, they're not able to appreciate the improved quality of life that they could have on
their
hospice.
Functional decline is so diminished at 6 months or less that
they're cognitively not intact anymore. They don't even know what's really happening, and so it doesn't benefit them. So it'd be nice to be able to have people come onto hospice with a longer life expectancy, or to really like you say model with the doing
concurrent
both.
care.
Concurrent care. Thank you. Concurrent care. Yeah, like pediatrics. Love pediatrics for that. It's a lot more challenging for case management, but it's so much better for them to be able to know that they can continue those treatments as long as they need to and still access hospice.
Yeah, and it's the right thing to do. People need this. They need wraparound support. They need a team to support them through not just the medical, but the existential, the psychosocial, the emotional, all the stuff that we all do very well. But you have to kind of check these boxes to get emotional support. It's just why don't we just do the right thing first and then figure it out on the back end?
Yeah.
That's why I won't be a politician, I guess.
Maybe you're the perfect person to be a politician.
Maybe when the kids are a little older.
Well, you mentioned, and obviously you've gotten to us, and clearly you're getting messages that are positive on social media. How's the rest of your social media experience been?
Honestly, it's been really nice. So this was not my first social media handle. I actually years ago jumped into social media by way of Twitter, under the name Palliative.
Also, I appreciate that you still call it Twitter because I refuse to call it X.
It's Twitter.
Bullshit.
It's Twitter. Yeah, I'm not caving into the egomaniac. Yeah, so I started Twitter back around like 2017, the early career days, just as a way of connecting with other people, and feeling a little bit less siloed in my day job. And it was a nice way to meet other professionals, but it was a Viper pet even back then. And it's been a very different experience on Instagram, where people are just like so happy to like see this stuff being talked about. They're so grateful, and like 99% of the messages I get are just from people that are just so thankful that like we're talking about this stuff. And every now and then I'll get like an irate lawyer or an irate insurance broker telling me that I need to get back in my lane. And I've very quickly learned to roll my eyes rather than like get all like bent out of shape about it. But it's been so nice. It just like feels like so much warmer and fuzzier compared to Twitter.
Go to Facebook. You can get a totally different experience.
I can get my fix there, huh?
Yeah. If you need your troll fix, go to Facebook. You can see the Murdered by Hospice Facebook group.
Those are so sad too, because I fully believe those people believe that, and just what a hard way to go through life, like thinking that you betrayed a family member or let them down. I don't know of a way of fixing that other than kind of doing what you're doing, which is saying, this is what it looks like. This is like the normal emotions that going through hospice, and I'm so grateful that you all are out there like putting that content out there, just like help people like understand what death and dying looks like. Here's what hospice does, and here's what they don't do. And I mean, just from the messages that I've seen people leave you in the comment section, and it sounds like you're just alleviated so much guilt from people that were clearly carrying some really heavy stuff before they found your work. And thank God for you, honestly.
Oh, thank you. Yeah, that's definitely the rewarding part. That keeps me going back, despite the Murdered by Hospice Facebook going after me when they do. But it's interesting that you said that that they feel that they've let their person down. I bet you that really is deep in their core the truth about how things are, but they are misplacing that anger and that guilt and putting it all on hospice and saying hospice, murdered my person. Although many of them just didn't have, they weren't the decision maker for their family member, and didn't agree with what the decision maker said needed to be done for their person on hospice. So it is, I try to avoid engaging with them too much, because I know that sometimes, grief can really impact people deeply, and they can do and say things that they would not have said weren't they grieving as deeply as they were. And I try to give them a pass for that, but it's hard sometimes.
It's very hard. It's very, and I feel like that's the constant calculus on social media when you get we'll call it a provocative comment. Do I want to make this a teachable moment? Because when I reply to those ones where they're clearly trying to bait you, this could be a teachable moment for someone that is coming across this comment like 6 months or a year later. It's less so for the person that's on there, and every and I get surprised both ways. Like sometimes I'll just get like the middle finger back in response, and other times I'll say like, but other times I'll be like, actually, thank you for that. That's helpful. I'm like, okay. Like, and I'm pleasantly surprised by the dialogue, but it definitely cuts both ways.
Sometimes it really just depends sometimes on how they phrase it.
There's no tone of voice on those comments. You don't really know what they mean.
Right. Yeah. So sometimes I'll make it a teachable moment, and sometimes I will blast them. It just depends
Yeah.
on what the comment is and how it's being presented to me. If they're calling
Yeah.
me a dumb fucking idiot and saying I'm too old to be on social media, they're usually not going to get a teachable moment from me.
Yeah. It's hard to believe they're making that comment in good faith. Yes.
Yes.
Yeah.
Yeah.
Yeah. That is why I like the videos, though, because to your point about tone of voice, I think it is so important to have the nonverbals and the intonations in this type of very sensitive content, because I think what I struggle with on Twitter too is it was very easy to try to just like share a reflection or something that I'm working on and just be called like preachy or like holier than thou, and I'm like no, I'm just like trying to like process some trauma as a group here, buddy. But sure, like I'm preachy or whatever. Like, whereas I think in videos, it's you get to express more of yourself, at least for the people kind of watching your videos. And again, with the comments, you don't know, but although you can probably guess the tone from that dumb fucking idiot one. But
Yeah.
yeah, yeah,
Yeah. I think it's a really great medium for us to be normalizing death and dying and improving the quality of people's lives at the end of their life, to have so many of us now out there. I mean, there are a lot. When I first got on TikTok, I think I was Dr. Sammy Winemaker said I'm the OG. I was the
yeah,
first one who actually started educating about death and dying on TikTok. And now there's so many hospice nurses and social workers and palliative care doctors and hospice doctors and chaplains. There's even chaplains too,
yeah,
and it's great to have so many death positive people who are trying to, improve our culture so that we can accept this thing that is absolutely going to have to happen to all of us in the end.
yeah, yeah. I mean, they say it takes a village to raise a child, and I think the opposite is true. It takes a village to see someone out of this world, and especially Western culture is just completely made and gone and done the death and dying in this like very isolating way where people don't really get that village. And I think we're just kind of creating one like through social. And I think that's just really cool.
Death with dignity is not legal in your state, is it?
No, they're looking at it over the past couple of weeks. There's been some news that they're looking at. Well, it's very confusing because the articles refer to it as Illinois looking at medical aid in dying, which is like a discrete thing that no one does in the states. But they're actually looking at physician assisted suicide, as is the case in a few other states, mostly on the coasts. But yeah, so we're looking at it here. We'll see. We'll see what happens.
Penny, do you have thoughts on that? I have a follow-up comment.
Yeah.
Go ahead.
Yeah. So medical aid in dying is in our state. The law was called death with dignity.
Mm-hmm.
Death with dignity, if I can enunciate my words, and nationally kind of known as medical aid in dying, which is still not my favorite phrasing because it still sounds like euthanasia to people that don't understand it. And that's not what we do.
Yeah.
We don't actually do anything except for help people through the process. So it's frustrating sometimes to hear other states as they're trying to decipher whether or not that's something that's good for the citizens of their state, especially when it gets confused with the word suicide, which is already loaded.
Yes. Yeah. It's tricky too. And that's sort of been the accepted term, even if I don't love it, but
I don't love it either.
But yeah, I do get even more nervous compared to Canada when they're medical aid and dying, is the physicians literally giving the drugs,
Yeah.
or administering them rather. Whereas here it's the prescription and the patient takes it, which is what Illinois is looking at. But yeah, all the terminology is just confusing terms on top of confusing words, and it makes it hard to talk about it and with reassurance that we're on the same page,
Yeah,
exactly.
Yeah, I that is so different in Canada, because that is euthanasia when the provider is actually administering the drug. That's euthanasia, and we can't even pass a federal law on medical aid in dying here, let alone would euthanasia ever be something that people are going to be okay with.
Yeah. Not in my lifetime.
I would agree. It's probably some ways off, if ever. We haven't even gotten marijuana down yet, so that would be
Exactly.
We have it in our state.
would be quite
In
the
fact,
leapfrog.
just kidding.
I meant federally. Yeah. That'd be
Oh yeah,
just
federally. No.
just skipping over the federal laws for marijuana and straight to the death.
Yeah.
That'd be quite the flex in Congress.
Yeah, no kidding.
I'd be
They're
pretty
too
impressed.
busy trying to ban TikTok.
Yeah.
So we'll see. Yeah. So you all have worked with folks who went through the program?
Several.
I had a patient who wanted to do it, unfortunately, because at that time the waiting period was much longer than it is now. We've just improved our waiting period time in Washington State. He had liver cancer, and he became very confused because his liver cancer was advancing, and he was no longer able to be considered decisional. And he had a terrible, terrible death. We ended up doing palliative sedation, which, see, I just said palliative. Palliative sedation, which to me was like, what's the difference, really? We're going to sedate him until his death. It was really a sad situation. His husband, every time I went to go see him, his husband would say, this is exactly what he didn't want to have happen. He was so agitated all the time. And so that was my experience with it as a hospice nurse. And now I'm a volunteer for End of Life Washington, but I have yet to go be with a person I'm just training right now. I haven't been with somebody, but I know Hallie, I'll let you talk about your experience because you guys are on the cutting edge at your agency.
Yeah. Without naming my agency, I have been lucky enough that our agency is a secular one, so it doesn't have the hangups of some of the more religious parent companies of hospices that haven't been able to be more involved. Even though it's legal in our state, that doesn't mean that all hospices are participating or are participating in various levels. Some hospices, their clinicians aren't even allowed to talk about it at all. One of the frustrating things about the VA is they're not allowed to even mention it because it's federally illegal. So, But that being said, I have assisted many people through the process. I have had the honor to attend several of the ingestions, and it's been really amazing. It's the first, I haven't really talked about this too publicly, but the first time I witnessed that, even though I'm 1,000% in support of it and will likely do something like that for myself if I'm able to and eligible. It's very different to see someone take medication and then die. And as opposed to watching the slower progression. And I'm trying to even stay away from the term natural death because medical aid dying is also a natural death. It's, assisted, but it's still natural. Still trying to figure out that terminology. But it's been amazing. There, with very few exceptions, and most of those were pretty early on. The medications have improved, and it's been extremely peaceful. Patients have gotten the autonomy that they wanted. Families are supported with hospice staff there. So, yeah.
That's cool. Yeah, I think so. I obviously haven't been a part of it, but I just from hearing people talk about it seems like a very powerful way of feeling in control of a situation. That the arc of the illness is obviously gets to a point where it's out of control, and just sort of having that reassurance that if you choose to, you can kind of choose to kind of name the terms that you go out on. And I think it's a powerful thing to give someone.
I think you have a great point too, because there's a lot of people that get the medication or the prescription, never actually pick it up or never actually use it. It really is that option of and just giving them the option, making it person-centered and honoring their autonomy, and then they just don't use it.
More people are starting to use it now in Washington, though. They definitely have seen an uptick in people using it. They don't have a really great way to collect data on it unless the person is involved with End of Life Washington, because you can get the prescription and you can fill the prescription and then you might never use the prescription. So unless there's somebody there that validates that the person actually used it, it's hard to know how many people are filling it. They don't know how many people are receiving the prescription and not filling it. So there's not a whole lot of really good data, but they have seen an uptick in people using it. That's definitely been something where End of Life Washington is now actually wanting to support hospice agencies like Callie's, who are fully supporting of doing it, like writing the prescription, helping them mix the meds, all of those things. They're trying to engage more hospices, and their goal is to get a hospice in every county that's willing to do that. And to that end, they're even putting money behind it. So our state is a certificate of need state, meaning that you have to apply for a license with the state, and they'll determine if they feel like there's a need for another hospice in that county. So we have a hospice that's wanting to get into Spokane County, and so they're applying for the CON. And End of Life Washington is supporting in that financially, and going to bat for them and trying to help them get their CON, because Multicare is willing to fully support death with dignity.
It's an interesting little bit of calculus there to kind of know what the right percentage of folks using that option ought to be, and how to measure like equitable access to that sort of thing too, because certainly like having that option in every zip code would be a good place to start, but then beyond that, like what's the accurate percentage?
Well, and cost is definitely a barrier for some people. It's not cheap. It's I think around $800 right now, and insurance doesn't cover it.
So I know it went up to like $3,000 at one point. It was very expensive. Yeah. And then a pharmacist came up with a different concoction of drugs to use that dropped the price down. So it is cheaper, but it's true. It's not affordable for everybody. Insurance doesn't pay for it. Insurance will never pay for it.
And pharmacies can opt out. So there's a limited amount of pharmacies that you can even get it from.
Yeah. Yeah. Yeah, it's an interesting thing too. I mean, even that on the cost, because I worry about the flip side of that. If it's cheaper than everything else, and I worry about this with palliative care. It's being a multidisciplinary team, and like having that sort of staff and resources costs a lot of money. And if a healthcare system has a choice between like the pill versus like the multidisciplinary team, I worry about the conflict of interest there, financially speaking. But yeah,
well, that's true.
But yeah, it's interesting that it's that expensive too, because then it feels like it. Yeah, I don't know where the right balance on that scale is either to make it.
Well, look at it this way though: $800 out of pocket to do death with dignity, or how many hundreds of thousands of dollars out of pocket for chemotherapy.
Yeah.
I mean, because that's not cheap either, right? So there's a conflict of interest there too. You could look at it that way and say, well, it's cheaper just to go ahead and end my own life than it is to do the treatment. It's shocking to me when I see people who are on social media trying to fundraise to pay for their cancer treatment.
It's cheaper than an ambulance ride home.
Yeah.
Isn't that sad?
Yeah.
I mean, this to our earlier point just about the broken system, and like this is the depressing part, right? That's just
Sorry.
People are all like, "Oh, this is really this conversation really got sad."
Yeah,
we're gonna turn it around.
Yeah, but I mean, it is true though. I think it's I think this is often where patients and healthcare providers kind of get pitted against one another, because they think like, I struggle with being complicit in the system, and you have to be somewhat complicit to be in it and try to help people. And it's just it's a hard thing. We all try to like find our rationale for that. Right?
All right, we're bringing it back up. All
right. Well, maybe, because I was going to just bring up something.
Penny.
Well, no, I was just going to say, and this is like not palliative care or hospice related, except that I'm a hospice nurse, and I've seen, I've been with thousands of dying patients, and I've seen hundreds of people as they took their last breaths. But last year, you were talking, Hallie, about the different experience of being with somebody who has taken the medications and died, right? Last year, I was the second on scene at what ended up being a fatality car accident. And I walked up to the car, and the man in the passenger seat on the front seat was dying. And I mean, I knew he was dying. He looked like he was dying. I've seen many dying people. I knew he was dying. And in fact, he did die later. Another person died as well. But that was the most shocking thing I think I've ever seen in my life, even though I've seen so many deaths. To see somebody dying that wasn't meant to be dying, and seeing them doing kind of the same things that a naturally dying person does, it was just so shocking to me. So
it's like all out of context.
yeah, it was really something else. I was just like, and one of the other people at the scene, I walked over to her and I said, that guy's dying. And she was just like, what the fuck? And I was like, oh, I'm a hospice nurse. That guy's dying. I'm telling you. Like, there was nothing we could do. I mean, we couldn't get him out of the car. They took the top of the car to get him out, and then they took him off by helicopter, and he did die. But anyway, okay, now we can try to bring it back up.
Oh, you want me to transition from that? Great.
We can talk about How to Train Your Dragon again.
Yeah.
People who love that movie.
It's a great movie.
Yeah, my son is a big time How to Train Your Dragon. Like, he loves it.
I mean, is it all dragon movies or is it just that one? Are you just like about animated dragons?
Yeah, I was gonna say probably not all dragons because I couldn't really get into Game of Thrones.
Oh no!
Those were the best dragons ever.
We can't be friends.
About?
I know that seriously marginalizes me. But
of all the things we've talked about today, that's it.
I'm too fuzzy huggy. You know, it's so violent. I just couldn't do it. The happy animated dragons are more my speed. Yeah.
That's fair.
It is a good show. How to Train Your Dragon is a good show. And also, full disclosure, my husband will not watch Game of Thrones. He watched the first episode with me, and once the boy got pushed out of the window, he was like, nah, I'm out.
Yeah, hard.
He never would.
Later. Yeah.
It's like, incest, killing children, I'm out.
Yeah.
I'm not watching this. So I had to watch it by myself.
Well, I'm glad to know there's one other guy out there. Yeah. There's dozens of us. Yeah.
You're not alone. Well, I wonder, now that we're coming to the end of our time, what is in your future? And also, in case we forgot anything, is there anything you want us to know about palliative care?
I would, I'll double down on making sure people explicitly understand that palliative care provides support related to your quality of life alongside treatment from the moment that you receive a serious diagnosis, which you can define however you want. But typically when we say serious, we tend to mean something that's incurable and will have implications on your life expectancy. But regardless of what that prognosis is, palliative care can get involved from the moment you get that diagnosis, and will help you with symptom management. We'll help you with care coordination. We'll offer you emotional support, spiritual support. We do that with a team, and people love us. I think I know in hospice care, people say, I wish we'd known about you sooner. And palliative care is the same thing. People always wish we've been connected sooner. So I want people to know that, and they should. I want people to get to the point where they're demanding it. Right. I want people getting a new diagnosis and saying, great, when am I going to meet my palliative care team?
Yes.
That's my dream for what I'm doing here on social, is empowering people to demand this stuff until the system provides it.
Well, and obviously we're connected, but where can people find you?
You can find me. I am most commonly trolling around Instagram at How to Train Your Doctor. And I am also on YouTube. I have some longer videos on YouTube as well at the same handle. And and I do have a website at the same name too, howtotrainyourdoctor.com. I'm getting tripped up now.
It's not just me.
Yeah.
And you have a newsletter that people can sign up for.
I do, yeah. So if you go to my website, on the front page, there's a conversation jump starter that I call it. And it's like a little 1-page PDF. And it's got a couple of conversational prompts that you can bring to your doctor's office that helps start the conversation about your goals of care and what's important to you. And this is sort of your amuse-bouche into training your own doctor in having these conversations. Yeah.
That's great. And we'll put all the links in the show notes. And I also wanted to ask you, my understanding of palliative care is that, I'm be dreaming about palliative care tonight, which is great. You met your goal.
Yeah, mission accomplished.
Terminal with any length of prognosis or life-limiting disease, correct? Don't have to be
Yes.
terminal to be on palliative care. You can have a life-limiting disease.
Correct. Yeah, typically something that's incurable, life-limiting in some way, even if you're looking at years ahead.
Right.
We're there. The
We're all
longer the better.
terminal.
Yeah.
We're all dying.
Right,
Some of
depending
us.
on how philosophical you want to get, but yeah.
That's what aging
Very
is.
Kantian.
Yes. Some of us closer to the end than others, but yes. Okay.
Matt, thank you so much
Thank
for being with us today.
Yes. Yeah.
Thank you for having me. This was great.
Yeah. Thank
We
you.
appreciate you. Keep doing the good work.
Yes.
Likewise.
Well, that talk certainly went real dark towards the end, but I'm glad we managed to pull out.
Yeah. Yeah. We managed to pull our way out of that one, but it was dark, but it was so good. And I mean, Matt is just a wealth of information when it comes to palliative care. And I mean, I just love his pathway, like right away knowing that he wanted to connect with people and that palliative care was the way to do that. If I was going to go on palliative care, I would want someone like Matt to be my doctor. He is
totally
so fantastic. It was
and I'm so
wonderful
glad he's on here as part of the palliative world to explain that part of it, because it does feel like there's more and more people in the hospice world joining in and educating, but we do need a little bit more upstream and that bridge between just routine care and hospice.
Yeah, we really do. All right. Well,
I know. Lots of good guests to come. Stay tuned. We'll just have to actually remind you that you need to remember to live, because someday
we'll all be dead.